We go on to our next speaker, Dr. Anup, who's a consultant ophthalmologist, vitreoretinal services and uveitis and ocular immunology from LV Prasad Eye Institute, Bhubaneswar, and he is going to talk on a case of toxoplasmosis. On to you, Dr. Anup. I think you have to unmute yourself. We can't hear you.
You can hear me?
Yeah. Go ahead, Anu.
Yeah, thanks.
Yeah.
This was one of the very intriguing cases in my career as a uveitis consultant, and I'm happy to present little things on this platform. So back in 2003, we had this kid of 9-year-old who presented with diminution of vision for 3 months. However, the blurring was for a year. He had an epiretinal membrane, partially detached hyaloid, and on zooming in, we could see some outer retinal dull pigmented, brownish yellow lesions. In the left eye, the story was slightly different. We had a relatively pale disc. We again had this outer retinal smaller yellowish lesions, and we had a pigmented lesion here. However, of interest was this creamy yellow lesion in the parafoveal area, along with some amount of RP atrophy. Back then, we did do an angiography which showed all of these lesions to be hyperfluorescent. And similar was the case in the left eye, except for the scar which showed staining. The lesion of interest, the creamy yellow lesion, was hyper, but it was not as intense as these outer retinal lesions. When done an OCT, this was SD-OCT back then, we saw an inner retinal lesion involving almost till the outer plexiform layer with the epiretinal membrane, and similar findings were seen in both the eyes. So back then we had little knowledge of what we're dealing with possibly, but this is knowledge of retrospect. We thought it as a young age bilateral disease, disc pallor with outer retinal lesions. One of the differential was DUSN. However, bilateral DUSN is a rare occurrence, and our second differential was a possible retinal dystrophy. We went ahead and did a full field ERG at 1 month follow-up, which showed normal scotopic and photopic responses in both the eyes. However, we did see some stunted waveforms in the foveal and parafoveal area on multifocal ERG in this field view. So we observed this case. The vision was maintained 20/60, and at a 6 month follow-up, we gave him some low vision aids. So years later, in 2017, we saw that the right eye, these outer retinal lesions were slightly less prominent as earlier. However, the ERM was persistent, and that there was a completely different story in the left eye. What we could see now, very, very diagnosable, was a case of focal toxoplasma retinochoroiditis. We went ahead, did an IgG, IgM, and started the patient on Bactrim DS. The vision had dropped from earlier 2060 to 2400. The IgG came out to be positive, and with routine treatment of a combination of antibiotics with a prednisolone, we could achieve this result of a scar with improvement of vision up to 21-25, with pigmentation appearing between 3 to 6 months. So this is the serial photographs, and 2013 there was this inner retinal lesion leading to 2017 a full-blown toxoplasma retinochoroiditis. And in retrospect, as we say, and we in retrospect thought this to be a case of a very rare punctate inner retinal toxoplasmosis, with both eye also having outer retinal toxoplasmosis lesions. So the question to think is, what's the significance of diagnosing this disease entity? Can we prevent this vision loss from 2060 to 2400? Can we prevent PORT going on to become a full-blown lesion? Now, Donald Gass says that yes, maybe there is a possibility that we could treat it at this stage and prevent this, but it's an open-ended question to see if we could really diagnose at these cases. So with the review of literature, Friedman had described this as first as an inner retinal lesion. These are punctate subcentimetric lesions, however, could be large in HIV patients, and we had some success publishing it, and we found out creamy yellow-white lesions autofluorescent white. These were ISO, and FFA was hyperautofluorescent. In our series, OCT, involvement was from the inner retina, the hyperreflective lesion, till the outer plexiform layer. So that's the case, and this is a burning question: that can we prevent inner retinal toxoplasma lesions presenting along with outer retinal lesions not to progress into blown full thickness toxoplasma retinochoroiditis lesion? And the second burning question is, if we treat these lesions, can we prevent a recurrence or sort of a progression to a full-blown toxoplasmosis? So I rest my case here and would be happy to learn from the panel.
Very interesting case, Dr. Anup. Shall we hear from you, Dr. Malika?
Excellent case, actually. It's quite an eye-opener. But having learned this now, would you now, if you see a case of PIRT, suspected PIRT, yes, would you first do a serology for toxo? And then if it is positive or even indeterminate, would you anyway treat so that at least the risk of reactivation or conversion to full thickness lesions in the near future is prevented? Would you do that or would you not treat?
I think, just there is only one reference in literature by Donald Gass, as I said, and he said that punctate lesions, you might go ahead and treat it. It's a very early evidence. We do not have any RCT or a meta-analysis on this, but logically, yes, if it's an infection, we should at least treat for maybe a period of 6 weeks, like we do in a toxoplasma retinochoroiditis case. But it's again an open-ended question. So the real thing is, are we really preventing those tachyzoids getting converted into bradyzoids, and how long to treat? No, that's the question.
But Malika madam, if you see here, the IgG was positive.
Yes,
and
yes.
So being that taken into mind, and do you want to treat that small lesion when, of course, first we did not know that was a toxo lesion, and IgG, if you check in other places also it can be. So do we have to be aggressive according to your question, even if we had done a serological test? And if the IgG was positive and it did not show a full-blown toxo lesion, and which was still a kind of question whether it was a toxo or not. So should we treat it just being IgG positive?
See, Dr. Srinivas, there's no harm in giving Bactrim DS to a patient. It's not the harmful treatment, provided patient does not have allergies or pregnancy. So I think that if there is a chance that they might come up with a macular lesion suddenly because we have not treated.
Time's up.
If you have a diagnosis, like he has made the diagnosis of PIRT, then I think it makes sense. So I think yes, if you have a diagnosis or suspect, treat it, 6 weeks of treatment. But to answer your second question, which you said whether it would prevent recurrence by treating, I don't think so. Because when we are treating real toxoplasmosis, it doesn't prevent recurrences. It's common, they continue to get even despite good treatment. So that would still happen. That would still happen, but at least in the near future, in the next few weeks, you would avoid a major catastrophe.
But Anup, when your first lesion started and when it went into a full-blown toxo lesion, what was the time duration between the two?
It was 4 years, Dr. Joshi. So it was 2013 that this happened, and 2017 was when the full thickness lesion happened. There was also a 2019 series by Yanuzi et al, which showed such a port with port lesion going on to become a full-blown toxoplasma. There, I think it was 5 years of a difference between initial presentation of punctate to a full thickness lesion.
So I think
Hemant sir and Malika, how long should we keep seeing this, and what should be our observation period? Because this we burnt our hands in this case. So how frequent should be the follow-ups, and any other suggestions you both have, any other expert panel?
Dr. Hemant, you can see.
I feel initially the patient was asymptomatic and you observed them, or was the patient symptomatic?
Vision was poor.
Vision was 20/60 and it was gradually decreasing over a period of a year, and 3 months he was having some diminution of vision. The blurring was since a year.
So I think at that time, because you feel that, the patient is symptomatic, and if you had done a titer, I think it would have, like what Dr. Malika suggested, treat the patient, then keep the patient on observation. It could probably have a different course. Cannot predict, but because recurrence can occur at any stage. So we are not preventing recurrence. But I think in view of that symptom, I think it would have warranted some treatment.
And in toxo, the best way to monitor is to ask them to self-test, close each eye, give them an amsler or just self-test. Then they can report a reactivation.
Yeah. Manish sir, want last comment?
Yeah, just quickly that the OCT showed extensive thinning, very symmetrical both eyes of the fovea,
Yes.
which is the only strange part of the whole case, because are we dealing with two things together, some sort of a dystrophy along with that? Because that kind of a thinning, extreme thinning in both eyes is not seen that commonly bilaterally with such a condition. That's my only concern with the whole thing.
So the only other thing which could be is DUSN, which can cause extreme
Yes.
thinning, extensive thinning. But ERG would not be normal in that situation, which was normal.
Yeah. And
Correct.
bilateral DUSN is again area I don't think is
And also the left eye, the superior to the disc, there was a scar, pigmented scar that was missed during the, not missed, but not thought of as a toxo. Possibly that was the primary lesion, the left eye superior to the disc.
Manish, if there was a coexisting disease, he would have had vision poor from childhood, earlier childhood, because if it was a retinal dystrophy, that's the only other possibility. But it was it's only 6 months following an infestation or intestinal something. So unlikely.
Can I make a quick comment?
Yeah, sure.
Yes, Dr.
Srinivas, yeah.
Yeah,
So one thing, clinically, these are very difficult to diagnose because the signs are very subtle. We tend to make a differential diagnosis of dystrophy versus infection versus so many white dot syndromes and so on. So I think one thing we can look at is the vitreous cells in the posterior vitreous on OCT. If that along with IgG for toxo, if it is positive in high titers, I think we should go ahead and treat with bacterium DS. And maybe if it is close to the fovea, give an intravitreal clindamycin as well. About the thinning, which Dr. Manish was noting, I think that is because of the necrotic nature of the PERT. It is an inner retinal necrosis, maybe a very subtle form, which causes thinning over after it heals. I think that is the explanation for the thinning. This is from my end. Yeah.
Just a last comment, 2018 to 2021, he has not developed any progression in the right eye. So to rule out dystrophy.
I think time is up now. Let's
Yes.
Let's move on. And
Nice
thanks
case,
a lot.
Well done. Nice case.
Very well done. And